Hi, this is Dr. Sam Sunshine at OC Sports and Wellness, and my guest today is Dr. Dan Duggan. He is actually in surgery. Hopefully he can make it at some point during the next 20-30 minutes. If not, it's going to be me talking about the knee and in particular meniscus injuries and what you can do about them. So I've got a knee model with me. So first, just starting with some anatomy. And this is a right knee. And so if you're looking at this, this is the front of the knee that's facing you. And we have the quadriceps tendon that comes down, and then there's the kneecap, and then we have the patellar tendon. And if I pull back on those structures there, it exposes the knee. We've got the femur, or the thigh bone, and then we've got two bones down in the lower leg. This one skinny one on the outside of the leg called the fibula, and then the shin bone called the tibia. And then if we look at inside the knee, maybe I'll start with those beige colored ligaments there. Those are the anterior posterior cruciate ligaments. We won't be talking about those today. We'll be focusing on these white colored, round, kind of C-shaped discs. These are called the meniscus, or menisci, plural, and they're fibrocartilage. They tend to be thicker on the outer rim and thinner on the inside. That kind of helps with knee stability. And you can see these parts of the thigh bone. These are called the condyles, and they fit nicely right in there. The meniscus kind of adds support, and these meniscus also act as a cushion. So when you're weight bearing, it's about 3 times your weight is just with walking is put on that knee joint. And so these cushions can help not only to stabilize, but to cushion the joint. So what's a meniscal tear? A meniscal tear is when you have a tear of one of these C-shaped cartilages. This could be the outside, which is called the lateral meniscus, or it can be on the inside. And they're fairly evenly distributed. Maybe the medial or inner meniscus is more commonly injured, but they're pretty symmetric. I want to make the distinction because there's 2 classifications that I think of when I think of meniscal tears. There's the young athlete who has a traumatic injury. This is usually during football or soccer. It's usually a weight-bearing pivoting motion that can occur. Skiing is another one, and that is one type, acute, usually happens in a younger athlete. And then you have a different type of meniscal injury. It's more degenerative, and that's usually associated with arthritis or degenerative process. So those are treated actually differently. Usually when people do tear a meniscus, they're going to have acute pain. And usually the pain is going to be somewhere in what we call the joint line, in between the thigh bone and the shin bone, either on the inside or the outside, depending on how they've torn it. Symptoms are usually you get swelling that tends to be more gradual. If you tear an ACL, which is a big stabilizing ligament in the middle here, usually you get pretty rapid swelling of the knee that happens over minutes. Meniscal injuries, you may not even notice swelling for hours, or maybe not until the next day, or maybe you had a pivoting injury, felt okay. Some people can even continue with their activity, and they wake up the next day and their knee is swollen. Oftentimes we think of a meniscal tear. Other symptoms of meniscal tears is a feeling of instability. If you have a significant tear, it might feel like that cushioning and that stabilizer is, you've lost that. So you might feel a little wobbly when you're walking, especially going up or down stairs. Another symptom, again, other than that feeling of instability or giving out, could be locking, and that's a pretty significant symptom. If I see somebody, even an older athlete or patient who has locking sensation, that's almost like the feeling of the inability to fully extend the knee because it feels like something is stuck in the joint. That's more of an orthopedic emergency. That usually is a torn meniscus that is now flipped into the joint, and it needs to be addressed. What we used to do when people had meniscal tears, they would go in and take out the entire meniscus. And what they found is it really gave patients issues with arthritis. So one of the things the specialists will do, the orthopedic surgeons, is try to just either repair the injury or do what's called a debridement, where they go and trim it down. So I kind of got ahead of myself there. So again, just talking about the anatomy and then how things are torn, what are some of your symptoms you might experience, and then, what are some of the treatment options? So when I see people who have an acute knee injury, I'm not a surgeon. Dr. Duggan, if he joins me, will get into more of the surgical details, how long the procedures take, how long it takes to heal and recover, and so forth. But usually what I try to explain to patients is, let's give it a chance to heal on its own. So the big question is, can meniscal tears heal? Generally, the blood supply is not great, and we generally say meniscus tears just don't heal unless they happen to be more on the periphery. This is the outer, maybe outer quarter of the meniscus. That area has blood flow, and you can potentially heal meniscus if you give it rest. Generally speaking, a lot of the tears are more towards the center of the knee, and those don't heal. They tend not to heal, especially if you have a large meniscal tear. It just generally doesn't heal on its own, no matter how much time you give it. I did have a tear in my meniscus a couple of years ago, and I just rested it, and it doesn't bother me anymore. Another thing is that sometimes when we injure meniscus, we injure other structures in the knee, and that giving it some ample rest, this tear may still be there, but it may not be causing you symptoms. And so just letting the other soft tissues heal, which again is about a 4 to 6 week process, using physical therapy, ice, stim, and things like that, compression. Some people get better and they don't have persistent pain, even though they may have a meniscal tear. So we've talked a little bit about anatomy. We've talked about how people can injure the meniscus. If you have any questions, please feel free to chime in. And if you are listening live, which would be great, if you can just put your name and maybe where you're from, that would be helpful as well. So with meniscal tears, generally if it's a younger athlete and it's traumatic, that oftentimes requires surgery. And starting in the mid-'80s, they started doing what are called arthroscopies. So it used to be an open incision. Now they make 3 holes, one for a camera, one to put in fluid, usually water, saline, to kind of distend out the knee. And they can go in there and they can, with the camera and tools, they can look at the meniscus. And if it looks like it's repairable, they can actually put sutures to hold that tear together. If it doesn't look like it's repairable, they can go in there and it's called trimming the meniscus. And what we found is that if you don't take out the full meniscus, but just trim it down, it preserves some of that shock absorbing benefit of the meniscus and can delay the onset of arthritis. Generally, what I have seen in my practice is if you do get a meniscal tear and it does get treated surgically, that oftentimes people will develop arthritis in about 10 to 15 years after the procedure. I don't think it's from the procedure, it's from the injury. Does that same arthritis occur in people who do tear but heal and don't require surgery? I don't know. I don't know. So that would be a good question to try that maybe Dr. Duggan would be able to answer. Again, talking about blood flow to the outer portion of the meniscus. The inner portion of the meniscus doesn't have great blood flow, so it just doesn't heal. In the older athlete or the older patient, if you do have degenerative changes, I don't recommend, I try to protect people from going into surgery for a meniscal tear unless they have locking sensation. And again, that's the inability to fully extend your knee because you feel like something is stuck in there. That's a clear indication to have surgery. But a lot of times when people have degenerative meniscus and there is a tear, that's not the cause of their symptoms. And so there have been sham surgeries done in other countries where they put everybody asleep, but only half the people end up getting their meniscus trimmed, and outcomes at 1 and 2 years are the same, whether you've had the actual debridement of the meniscus or if you just thought you had surgery but you didn't have debridement of the meniscus. let's see, other conditions to think about and criteria. There's been, one of the things that I'll do is PRP and prolotherapy in soft tissues. Again, I do not think those injections will heal a meniscal tear. Again, if you're symptomatic and you're having locking symptoms, you're a candidate for meniscal surgery. If you're a young athlete and you've had a traumatic event, I think, again, you're a candidate for meniscal surgery. How do we know if people have a meniscus tear? There are several tests we can do that are done in the office. They're not super sensitive and they're not super specific, but it gives us an idea. Most of them involve bending and then kind of rotating the knee. I won't get into the specifics of those, but those are things, and you can go into YouTube and watch how you can self-diagnose a meniscal tear. Again, not super reliable, but they can give you a hint. A lot of them involve standing and then rocking with your knee slightly bent. But generally the best test is not an x-ray, and unfortunately not an ultrasound, but an MRI. An x-ray will do a good job showing the bones and their outline. Ultrasound is good at looking at maybe soft tissue tumors, fluid in the joint, and an MRI is really good at showing cartilage, meniscus, and they're very good at picking up small meniscal tears. So another thing, another study I read is for patients over the age of 40, if they were just to randomly get MRIs of the knees, there's about 40% of patients that will have a torn meniscus and they have no knee pain. So I always caution the older athlete who's not symptomatic other than just having some joint line tenderness that if you get an MRI, there's about a 40% chance you're going to see something. And that often will lead to a surgery. And I think that's unnecessary. If Dr. Duggan shows up, again, he added another surgery to his schedule this morning, so I know he's anxious to get here, but I told him not to speed on the freeway. So if he doesn't show up, we won't get those answers, but maybe we can schedule him for another time. But I always caution people, if you get an MRI of your knee, there's a 40% chance you're going to see something that's probably insignificant, but it may end up leading you down the path towards surgery, which I don't think is a good idea. There are some surgeons who are very conservative. I've had patients who go to one surgeon and say, yep, you need meniscal surgery. They'll take that MRI and go to another orthopedic surgeon, and they'll get a different response. And that doctor would say, you know what, do some physical therapy, give it some time, and they may ultimately not need surgery. So I tend to be somewhat conservative, especially in somebody who's over the age of 40. Even if you're an endurance athlete or you're a running athlete, giving your body a chance to heal it is probably a better bet than just rushing in to get surgery because maybe you have races coming up and you want to get it behind you. I think that's a mistake. So we've talked about the anatomy, we've talked about how people injure the knee, what are some of the symptoms, how we would diagnose it, and then the treatment options. Again, before I would send an elder athlete to a surgeon, I would oftentimes recommend a trial of physical therapy, some rest, compression, and see how you do. Give it about 4 to 6 weeks, and that can be hard. If you're a runner, you can do pull running. You can still try an elliptical, but I just wouldn't do any actual running. You can try biking. Biking is reasonable. If it does bother you, then I would, of course, I would avoid that. I'm not a huge fan of anti-inflammatory medications. They do not expedite healing, and in fact, they may be harmful. They can raise blood pressure, they can cause stomach ulcers, and they do not benefit the healing process. In fact, they retard it. So I'm not a huge fan of anti-inflammatories. Again, I like ice or heat, compression for knee pain. If you have arthritis, there's a whole host of things you can try. Everything from curcumin to cosamine, which is glucosamine and chondroitin, or just glucosamine alone. And those are things that you might try for just knee pain in general, not specifically for meniscal tears. So again, if you have any questions, don't hesitate to type something in. Again, we're talking about meniscal tears. Again, the shock absorbers of the knee that are commonly, they get degenerative as we get older, kind of like tread on a tire. And the more active we are, the more weight-bearing exercises we do, such as running, soccer, tennis, we're going to have more wear and tear on our knees. So, but with that said, exercise is still the most important thing you can do with your day, is try to get exercise every day. Shoot for 30 minutes, try to make a sweat, get your heart rate up. It reduces all-cause mortality. And if exercise came in a pill, we would all be prescribed it. All right, so again, here's a question that says, can meniscal injuries heal themselves? Again, certain ones may be able to heal themselves if they're more on the periphery of the meniscus. Again, what we see, because if we get this rotational flexion type of an injury, it's more like a mortise and pestle. It's usually going to be that inner portion meniscus that doesn't have great blood flow, and those generally will not heal great on themselves. How do you determine whether to trim or repair a meniscus is another question that just came in, and that's really, again, a great question for the surgeon. Generally, if it's a younger athlete and it's a pretty defined tear, one that's maybe we would call it a radial tear where the edges are just apart, they can put a stitch in there to try to preserve that meniscus. Larger tears are harder to repair, and larger tears are like a complex tear. Usually they don't repair those, they're too difficult, and generally they'll just trim those pieces out. And then the healing time usually is about 4 weeks, 4 to 6 weeks after a meniscal injury before you're back doing weight-bearing exercises. If you do have a repair, usually you're non-weight-bearing, using crutches for about 4 to 6 weeks before you can put weight on it. So the recovery is much longer, much more difficult if you have a repair. But if it were me and I was a young athlete and I had a significant tear and it was repairable, I would opt for repair, because you want to try to preserve as much of the meniscus as you can throughout your life to reduce the risk of developing a degenerative process called osteoarthritis. And there are now estimated 20 million people in the United States have degenerative arthritis in their knees alone, and it's a big, big problem, in large part due to the growing obesity epidemic we have in the United States, and sedentary lifestyle, surprisingly. It's not from overuse. So let's see if there's another question. So is physical therapy required after meniscal surgery? Generally, I think when you have a meniscal surgery, that you're going to be immobilized for up to 4 weeks. Generally, let me rephrase that. You're going to be not exercising with weight bearing for about 4 weeks, and so those muscles will atrophy. The muscles of your thigh, your calf, even your core. And so I think it's important to get back into physical therapy. If it's a debridement, you could probably start therapy as soon as 1 to 2 weeks after your surgery. If it's a repair, generally that rehab starts about 4 or 6 weeks after the repair is done before you do formal physical therapy. And that may vary. This is where I would probably defer to the orthopedic surgeon for more detailed information on that. All right, well, if there's no further questions, I'm going to conclude today's Facebook Live talking about meniscal injuries. If you do have any questions, again, I'm Dr. Sam Sunshine, OC Sports and Wellness here in Foothill Ranch, California, and I'm a family medicine trained, board certified in family medicine, also board certified in sports medicine. I don't operate, but if you have any musculoskeletal issues, I use a lot of musculoskeletal ultrasound, and then also do therapeutic injections with prolotherapy, PRP, and stem cell therapies. Thanks so much for watching.